Hepatitis B in pregnancy. Hepatitis becomes an important discussion is because it is the world's most common bloodborne infections, and it's affected about 5% of Malaysian population and about 1 to 20% of the world populations. So it is very common, and most of the time 80% of the case means subclinical or very mild, so it can go unnoticed. But from this 20% of the world populations, 90% of them actually, after get infected, they can become fully recovered, and does not carry this virus. It's only 10% who become a chronic carrier of the hepatitis. But why it is very important when we talk about hepatitis in pregnancy is because we worried of the transmissions to the fetus, because the aim of the WHO by 2030 is that to eradicate about 90% of the hepatitis in the world, and also to reduce about 10% of the mortality rate as a result from hepatitis. So the reason being because hepatitis, even though it is mild, if the fetus get infected from the vertical transmissions, especially 95% during the intrapartum period, what happen will be the fetus can easily have complications of the hepatitis, like hepatocellular carcinoma, liver cirrhosis, chronic liver disease. So that is why it has become one of the world screening protocol, that we screen all the pregnant lady with hepatitis B. So the route of transmission is multiple, and one of it that I want to highlight is the bloodborne itself. It can be transmitted from the needle prick injury. That is why it's very important as a specialist to make sure that the staff that in charge of the labor room and also operation theater who handle the hepatitis B carrier patients basically have their vaccinations, and make sure that the level of the titer of the vaccination, the hepatitis, is adequate enough before they handling these high-risk patients, because the needle prick injury alone for hepatitis B is 3-fold higher compared to the HIV. So we know that in HIV it's about 1%, but in hepatitis B, it carries 3% risk of transmissions for the needle prick injury. Secondly, it is quite common in the intravenous drug user to have hepatitis B, and also bear in mind that our blood transfusions also carries a risk of hepatitis B transmissions. That is why it is very important to analyze again and critically appraise the usage of the blood products in the hospital, especially during primary postpartum hemorrhage, things like that. So apart from the bloodborne, it also can be transmitted via the sexual intercourse, and also any bodily fluids that gets into the wound of the non-infected human also can become one of the transmission. And also we talk about the vertical transmissions. And for the vertical transmission, it's very important to understand that even though the intrapartum vertical transmission is very high as 95% compared to the transplacental during pregnancy, the mode of delivery does not significantly influence the transmissions rate. That is why, unlike HIV, regardless of the viral load of the mother, we didn't really change the mode of delivery. So there is no robust data to suggest that cesarean section can reduce the vertical transmission intrapartum to the fetus. So regardless, the patients delivered via vaginally or cesarean sections, the risk is still very high. That is why, fortunate enough for hepatitis B, we have this a very effective immunoglobulin to be given to the neonates to prevent the hepatitis infection. So one of the symptoms that the patient might present with hepatitis is that about 50% of them might not have a jaundice. So jaundice is not a common presentation for the hepatitis, and mainly the patients will go with non-specific symptoms like general malaise, nausea, vomiting, right upper quadrant pain, and also diarrhea. So it is quite difficult unless we screen the patient. That is why the serology is very important, where we do all serology to all patients, pregnant ladies. We send for hepatitis surface antigen, and if it's positive, if it's negative, then okay. If it's positive, then we have to send further serology. And the serology that we want to look at is actually how effective the patient is. So we want to see the HB envelope antigen, and that shows the level of infectivity, and also anti-hepatitis envelope. It suggests that the immune is responding towards the infection. And also, if we found that the HBE antigen is high, then we have to send for HBV DNA viral load. And if it's more than 200,000 copies, then we have to get our team member to involve with the management of the patient. So we need to ask help from the gastroenterologist or hepatologist, or probably infectious diseases physicians, to see whether these patients will benefit of the antiviral like tenofovir or telbivudin. So usually if the viral load is low and does not require any antiviral, so there is a role of repeating again the serology or HBE or viral load at 28 or 32 weeks, like what RCOG recommended, and start the treatment if required. So after that, we have to do further workout. Apart from the serology, we have to send for liver function test to see is there any transaminitis that raise of the ALT and AST. And bear in mind, ALT also ALP also can be alkaline phosphatase also can be raised, but usually it is not significantly raised like alarming. Usually it just 3 times more than the normal reading. And it is mandatory to get a baseline ultrasound of the hepatobiliary system, and then discuss with our during the MDT about the patient. And of course, as one of the prevention during the delivery itself intrapartum, we have to make sure one, our staff already vaccinated, and then they use a standard universal protocol, which includes a proper PPE, a double gloves, an apron, a face shield or goggle, just to protect their mucosa from getting a route of infections. So I'm sure in a lot of hospitals we have a spatial room, isolated room for the infections, for the infectious cases like hepatitis, HIV, where we use a single use items like delivery sets. We don't use a normal protective cover for the patients. We use a different, it's just single use, and we have to discard in a separate system. And of course the placenta management also, since in Muslim community usually we bury the placenta, but I think if the mother has a very high viral load, then it is wise to discuss with the patient and the husband before the delivery for the hospital to incinerate the placenta so that it is safer for the community. And also the baby must be attended by the pediatrics team. We have to get them involved and tell them about the severity or the level of infectivity of the mother, and get the active and passive immunizations to the fetus. So we need to make sure that the immunoglobulin must be given 12 hours within first 12 hours of life, and the vaccinations for the first 7 days of life is completed. And we have to emphasize to the mother for her to make sure that the baby is not infected with hepatitis B. She needs to make sure the vaccinations is followed and completed. So as for the national guideline, we are advocate the hepatitis B vaccinations together with the DTaP, inactivated polio vaccinations, and also the human influenza virus vaccinations at 2, 3, and 5, and repeat it again at 18 weeks. So for them to complete the vaccination is very important, and the mother needs to know that the breastfeeding does not really affect the risk of the transmission, especially if she completed the immunoglobulin and also vaccination. Since we know that the immunoglobulin is very effective, it can prevent about 90% of the transmissions rate. So the complications that we want to avoid for the fetus is that Fortunate enough, hepatitis B does not carry any congenital anomaly to the fetus, but what we worried of is the risk of the fetal to develop all the complications, which include the liver cirrhosis, hepatocellular carcinoma, and also liver disease.